Hello, everyone, and welcome to CAEP National Grand Rounds. I'm Jennifer Bryan, an emergency physician at the University Health Network in Toronto and chair of the CAEP Anti-Racism and Anti-Colonialism Committee. I'll be your moderator this evening. Tonight's session is on policing the emergency department. It's presented by the CAEP Anti-Racism and Anti-Colonialism Committee. This committee was formed last year in response to the recommendations for addressing racism and colonialism in emergency medicine presented at CAEP in 2021. Our work today is in the spirit of moving towards reconciliation and anti-racism. And I'd like us to begin with a land acknowledgement. To recognize the land is an important expression of gratitude and appreciation to those whose territories we reside on. Land acknowledgements aren't solely about the past. Canada's treaties and ongoing relationships with Indigenous peoples are current and ongoing processes. As we gather today in this virtual space, we acknowledge and pay respect to the many First Nations, Inuit, and Métis people and their traditional territories on which we live, work, and play. I'd like to acknowledge that I'm speaking with you from the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and I'm grateful to have the opportunity to be here to moderate tonight's session. Our objectives tonight are that by the end of this session, participants will be able to identify relevant legal frameworks guiding the role of police and security in the emergency department, be aware of provider level and departmental strategies for avoiding conflict in the ED, be able to recognize equity issues and concerns about racism and discrimination in police and security interactions. This is going to be a very frank discussion about challenging topics relevant for all emergency physicians. And I'm excited to see where this conversation goes and excited to see the questions that you have for our speakers tonight. Our speakers are Dr. Claire Bodkin and Dr. Suzanne Schusch. Dr. Claire Bodkin is a queer femme, community organizer, and family physician. She's a white settler living on Treaty 3 Anishinaabe and Haudenosaunee territory, which is also covered by the Dish with One Spoon Wampum Treaty. Her clinical and research interests are the care of people who use drugs, people who are incarcerated, people who are deprived of housing, and people who are queer and trans. She believes that health is political, and that health workers must have an analysis of power to address the root causes of poor health and health inequities. Dr. Suzanne Schusch is an Indigenous Black physician and mother who lives and works in Toronto's downtown core, where she spent more than a decade working in the city's shelter systems. She's the Indigenous Health Faculty Lead for the Department of Family and Community Medicine with the University of Toronto Faculty of Medicine. Dr. Schusch is actively involved in the COVID-19 pandemic response for people experiencing homelessness, as well as medical director of the Odejez Mino Nizi Winong, or Place of Healthy Breathing, a COVID testing and vaccine clinic for Indigenous peoples and their families. She's also the lead physician of 3 community and culture-based Indigenous clinics, Call Auntie, Ode Min, and Namirez. She's one of the founding members of Doctors for Defunding Police, a group of physicians advocating for systemic changes and structural justice. Our disclosures are shown on this slide and include that Dr. Bodkin receives research funding from CIHR and that Dr. Schusch receives funding from CanMod NSERC and is a board member with Partners in Health Canada. We'll be having a Q&A in the second half of this session, so please post your questions in the live stream. Now I'm going to turn things over to Dr. Schusch for this evening's first presentation. Dr. Schusch.
Thank you so much, Jennifer. That was a lovely introduction. Thank you for having me today. I really feel like there's so much to say in these 15 minutes, and I always hate that I can't see people's faces because I love to watch you guys laugh at my jokes. There's so much to say in these 15 minutes that I really want to try and make points that are the most relevant to you in your roles as emergency room physicians. So I wanted to back it up, and I wanted to talk about your roles as emergency physicians. Really looking at the roles that you play as a doctor are twofold. The first role is to be competent clinical experts. And the second is to really use your position to observe the world that you see, use fresh eyes, and use your privilege to advocate for broad improvements in well-being and health for the communities that you serve. Okay. And it's definitely surreal to be here at the CAEP National Grand Rounds as a Black and First Nations person, as a woman, as a mother to 3 Black sons, as an intergenerational residential school survivor, and to be here specifically to speak about defunding the police in the context of healthcare, and also why advocacy around addressing systemic racism and poverty is critical to your work. It's really incredible. And I commend the CAEP for just starting the conversation. So thank you so much. I was asked specifically to speak on supporting you to be able to recognize equity issues and concerns around racism and discrimination in the police and security interactions. And we're going to leave all the complicated legal wrangling out of this, thankfully. So again, starting from the basics. One of the most important things to understand is why there is a concern surrounding policing, systemic racism, systemic discrimination, and systemic poverty in relation to healthcare. And I wanted to start by just talking about, what is the definition of wellness and health? What makes a community well and what makes some communities sick? And honestly, the answer is simply privilege. I think that privilege is probably the number one most important and only social determinant of health. Having economic and political influence, being an empowered community. You see these communities that are empowered are healthy and safe, and disempowered communities are insecure with high burdens of disease. And then you're wondering, how does the current structure of policing relate to us as healthcare providers, especially in the emerge? And I just want you guys to back up and consider really like the structure of policing. So if you know that the structure of policing is really built on an explicit relationship of non-consent with Indigenous and Black communities, okay? Indigenous and Black communities were unequivocally denied the opportunity to contribute to the norms, the values, and the laws that police enforce. Our structures of criminal justice were established using colonial philosophies on land, resource, rights, ownership, and it's these colonial views that are rooted in resource extraction and the racial superiority of the colonizers that law enforcement is founded on. And we all know that by definition, a relationship of non-consent is a relationship of violence. And so essentially, when the police are enforcing the laws of our society, they're by definition enforcing a colonial system that was not built for, designed by, or intended to serve and protect Indigenous and Black people. And this is, again, the systemic tone of policing. This is not about individual police officers or individual police policies or protocols. We're talking about the systemic tone of policing that is rooted in anti-Indigenous and anti-Black racism, right? And it's not policing only. It is not only policing that has issues of embedded and systemic racism. In Canada, we took a centuries-long, very clear legislative process to systematically disenfranchise Indigenous and Black communities. This was a centuries-long process of hoarding resources, which includes basic infrastructure like healthcare, roads, education systems, everything. And these resources are generally hoarded in non-Indigenous and non-Black communities. So after we have this centuries-long process of marginalizing the communities, we then go on to develop these false mentalities of scarcity when it comes to correcting course. And suddenly we start to feel like, or, we hear again and again that there's no resources to cope with the mental health crises, with overdose epidemics, with climate change, with housing crises, with childcare, with physical well-being, with everything that we need to address for real wellness. We don't have resources to address these issues. And yet we see year after year, the police budget continue to be increased with an unattainable mandate. And it really seems like this is not an evidence-based decision-making process, right? We know that healthcare itself is really plagued with implicit bias, right? So it should be clear to everyone why the biggest trust gaps in both health and policing are with Indigenous and Black communities. And we also want to be clear now, the biggest the biggest health and the biggest criminal justice inequities are felt by Indigenous Black communities. Okay. So when you back it up to you guys and you're in the emerge and you're dealing with a patient that's brought in by the police, there's just a few things that you need to always remember. Number one is that people of color experience violence in interactions with the police, and that is just because the system was built this way. It's very much not broken. It's very much built this way. It is a fundamental relationship rooted in violence and non-consent, and that is a traumatic relationship. Okay. Number two, we know that we cannot police our way out. We cannot emerge department our way out of issues of systemic poverty and systemic racism, right? And we know that a lot of the reasons that people end up in emerge departments, the solution is not found in the emerge department. Okay. I know that you guys could do it if it was, but it's not. Number three, we know that police enforcement is inferior to community support in curbing violence and creating health and safety and wellness, right? Communities that are healthy have very minimal interactions. Safe communities have almost minimal interactions with the police, okay? Number four, we know that the police are involved disproportionately with communities who are Black, Indigenous, people who use drugs, people who are experiencing homelessness, and other marginalized community, right? So when we're looking at debates about defunding the police in the context of healthcare, a lot of this centers around the moment of crisis of a police interaction once 911 has been called. It centers around issues of police brutality, of police shootings, of people in crisis, of mental health escalation issues. And a lot of it is that's an incredibly important point, but it misses the entire backstory and the entire centuries-long process that it took to create the condition of the crisis. So we're not looking just about rightness or wrongness of the moment of a police interaction in your hospital, but we're also trying to look at the rightness and wrongness of the conditions, which we have taken centuries to cultivate. And it's really the conditions, how right or wrong these conditions are, that keep leading to 911 being called in the first place for these marginalized communities. The next point was, looking when people arrive in the emerge in the custody of police, it's very important to take a trauma-informed approach, okay? The impact of the distress and stress and trauma on the patient is not only coming from their healthcare crisis, but there is also a high adrenaline fight or flight experience from the police interaction alone. I do not know one person of color in this country that does not feel anxiety at any interaction with the police, whether it's a simple walking past on the street or a car being pulled over, then that is under conditions that are not the same as a distress crisis health scare, okay? So remember that the patient is in front of you in extreme distress. It's also really important that you remember that police and patients experience crisis interactions very differently. The way that the police experience a crisis interaction when they're called to a healthcare crisis is going to be always different than the way that the patient experiences it. And I find that just, socioeconomically and privilege-wise, we're much more likely to be interacting in a professional manner with the police than we are with the patients. And that's very important because that can shape the way that you decide to provide care for your patient or decide to characterize your patient. Patients themselves are really truly in fight or flight and freeze mode on arrival. They might not be in a position to give you their history, and that means you have to be careful about how you take their history. You have to be careful about how you frame people in your history. This is incredibly important. The number of times that I've had to look up patients of mine in my call auntie clinics or Name Res or any of my Indigenous clinics to read about what's happening during a police interaction, the words angry, combative, hostile, words that paint a picture of a patient that is being criminalized, essentially, are always popping out. And remember, these are our normal human reactions. This is a fear reaction. This is a vulnerability. The patient is experiencing something that is beyond their control in a situation where they know they could truly die at the hands of a police interaction. They could experience all kinds of healthcare stereotype bias. They could experience neglect. They could experience so many things. And that is, I think that I would also be angry and combative and hostile in those circumstances as well. Okay. You really want to think about how your words in the context of this crisis, how that contributes to healthcare stereotype threat. Okay. The words of the emerged doc carry through to every single physician that sees that patient. I watched the words of the first interaction with the police doctor, with the emerged doc that the police have given them carry through all the way to inpatient, ICU, to the specialist consults, to the outpatient, and then the words will be then repeated in the family doctor's chart. So that's really, really important that you're understanding the context behind policing, the context behind healthcare, the context behind, anti-colonialism and anti-racism. And the other thing is, you also want to be aware of how you interact with the police, right? The police will paint your perception of the person that they've brought in. It's almost impossible not to feel some kind of a way when you see the police carrying someone in or bringing someone in, or you get the call that that there's a police accompaniment. And just be aware, like, how does that change your opinion of what this person's, the validity of their care seeking is, the validity of their pain, the validity of their very presence in emerge? Is it frustrating? Is it different? I've seen some very egregious examples where the police have provided entirely inaccurate collateral histories to a patient presentation, and those histories, for some reason, when they come from the words of the police or they come from the words of a security guard, are taken more seriously and very hard to adjust afterwards. Okay. So, we all know at the end of the day that our solutions to health and wellness are not in policing. It's not in criminalization. Our solutions are really looking at how do we take resources and how do we use our voices? How do we use our privilege to build privilege, right? We want to invest in communities. We want to support growth. And I think that it's really important that we want to defund. I really feel strongly that it's important to defund the police, and we want to resource alternative possibilities, right? And we have to shift away from this reliance on a colonial system of anti-Blackness, anti-Indigenous racism, exclusion, punishment. The system has shown it is not only deadly, it is incredibly inefficient. It's a huge waste of resources. We can build health. And I'm sure that the more we defund the police to invest in our communities, the less we will need the police to begin with. Okay. And I know my time is almost up. I actually prefer question and answer. I'm not a presentation type person, and I would like to save some space for that. I didn't even talk about security yet, because that's a whole other issue in and of itself. But I'm just gonna pass it back to Jennifer so that we can hopefully move on to have a deeper conversation. Thank you.
Excellent. Thank you so much, Dr. Shush. An excellent way really to set the context for tonight, really talking about what our role is in the emergency department and the opportunities that we have to support our patients. So thank you so much for starting this conversation tonight. And yes, and please put your questions in the Q&A in the live stream, and we'll be having a Q&A in the second half of this session. Right now, though, I would like to turn things over to Dr. Bodkin. So Dr. Bodkin.
So I'm a family doctor, and I work in sort of more traditional clinic-based settings. And I also work as a family doctor in emergency departments in rural and remote communities. Last year, I was called to assess a patient in the emergency department. And when I arrived there were two police officers stationed on either side of the door to the room that this patient was in. When I went in to see him, I asked him, what brought you into the emergency department today? And he let me know that he had been quite brutally assaulted and left outside and was unable to get to help or call help. And some passersby had seen him and asked him if he was okay, if he needed anything. And he asked them to call the ambulance because he was not okay. So the passerby called 911, and the first responders to show up were the police. And so the police saw that he was talking and he was conscious, asked him his name, ran his name through their database, and found that he had outstanding charges and arrested him before the ambulance arrived. The ambulance then arrived, assessed him, transported him to the emergency department, which is where I saw him with the police still accompanying him. As he was telling me this story, he was actually very matter of fact about it. He didn't seem outraged that the police had brought him in. And I was sitting there thinking to myself, oh my goodness, like I kind of can't believe this is happening. And as I took a minute to reflect on that, I realized that the reason that I was surprised, the reason that I was shocked is because I, as a white person, as an upper middle class person, my interactions with police are fairly minimal. And generally, I don't see the police as a threat to my safety, nor do I see them as sort of an expected and usual part of existing in the world. And so I really had the opportunity to reflect on the fact that that is not everyone's experience. Of course, you know, for many people, the police do not represent safety. They do not represent that they're going to get help. They instead represent all of the things that Suzanne talked about. They represent harm and violence and a system of non-consent and centuries of racism and colonization and, of course, ongoing violence today. It also made me realize that, you know, of course, many patients are going to see healthcare providers and physicians, particularly physicians working in the emergency department, as part of the same system of police who harm them, as acting as agents of police or collaborating with police. Because when you call 911, you get police and fire and ambulance. So when you are in an emergency and you need to access care and you're out in the community, there is no way for you to contact and access only emergency care. There is always that concern. There's always that risk that police will show up. And it's really one system, not two systems. And I think as emergency physicians or physicians working in the emergency department, it's important for us to reflect on that. You know, I've never met an emergency physician who thinks of themselves, or any physician who thinks of themselves as an agent of the police or as, you know, part of the same system as policing. And yet for many of our patients, or the patients that we care for, this is absolutely their experience, that we're really just one system and different parts of it. But having that awareness can then lead us to do something about it, to shift that, to change that. I think, you know, Suzanne did such an excellent job of laying out the systemic factors that shape everything that leads up to us having an encounter with a patient in the emergency department who is detained by police or correctional officers, or where security is involved. And I think that sometimes when we're asked to consider that context of racism, of colonization, of these big systems that exist so far beyond and outside of ourselves, of the moment we find ourselves in, that can feel really overwhelming to shift. Harsha Walia is an organizer on the West Coast, on Coast Salish territories. And she did a podcast interview recently that I listened to, and something she said really resonated with me, which is that, I'm paraphrasing, but, you know, of course, these systems of oppression are massive, and they're intersecting and they're everywhere. However, although that can be overwhelming, the other side of that is that when you work on things where you are, when you are in your role as an emergency physician, providing care, working as an advocate, working on anti-racism and working on anti-colonialism and working on building a healthier, liberated, more just world for everyone, even though you're working in your small space, in your little corner of the world, because everything's interconnected, you're actually working on all of it. You're working on dismantling all of the violence and harm that exists in the world. And so we start where we are, we do what we can, and we're contributing to that overall work that is for all of us to do together of building a more just world. So I hope to offer a few strategies for what we can do as providers working in the emergency department. And I'll start by looking at what the legal and ethical frameworks are that guide some of this work. So I think the first thing that's really important to know is that when a patient comes in and they're detained, they have the right to confidentiality still. If they're brought in by police, if they come in, say they're unconscious in a trauma resuscitation or something like that, they still maintain their right to confidentiality. And this is really important so that people don't see us as agents of the police and will continue to seek medical care because they know and can trust that their confidentiality will be maintained, and that as physicians, we still have that duty of confidentiality to all of our patients. The CMPA shares some details on physician interactions with the police that I think is actually quite helpful for understanding some of the legal frameworks. The settings in which we might disclose information to the police are actually very narrow, very limited. So, I am not a lawyer, so there is a big risk here that I've oversimplified things, but hopefully also I've been able to share them in a way that's understandable for the vast majority of us who are all non-lawyers as well. So the exceptions to the duty of confidentiality, one, are legislative requirements. So for example, every province and territory has some sort of legislation on mandatory reporting of gunshot wounds. So there are some legislative requirements where you just have to report that to the police, given the current system and current laws in place, which of course, as Suzanne has pointed out, are all part of the colonial project and all designed to disenfranchise Black and Indigenous communities. The second situation in which you might be forced to disclose a patient's health information is a search warrant. So when a police officer has a search warrant, you need to examine the warrant, read it, and only disclose the very specific information that has been court ordered. You are not allowed to disclose any information on the basis of a police officer looking for grounds for a search warrant, or a police officer saying that they are going to get a search warrant. And even, once there is a search warrant you're looking at disclosing, ideally you would be talking to the CMPA and to the hospital's legal counsel before you would be making any disclosures. Along with this also means that the police do not have any right to direct an investigation. They cannot request an X-ray, a blood sample, a urine sample, anything like that. They're not entitled to request that be done, and also not entitled to request the patient would need to consent to that. And I think it would be fair to question if they could give free consent while police are there and sort of overseeing their care. And then finally, you might receive a subpoena or summons to appear in court. Again, this isn't a direction of any particular information. It's just that you, as the person who's been summoned, has to appear in court. And then either the court can order you to disclose certain information, or your patient may give their consent for you to share information in a court setting. But beyond these three parameters, there really are not any other reason why we should be breaching a patient's confidentiality. Of course, we know that the legal framework is really a ceiling or a floor, not a ceiling, right? It sets the bare minimum of what we can and can't do, but it doesn't really tell us, okay, what can we do to actually make this experience better for the patient? So one of the things I was fortunate to do is I worked with other physicians, medical students, nurse practitioner, and lawyers to create a zine on caring for patients while they're detained. And then we had the zine reviewed by people who have received care while they were detained. And the first edition of the zine only kind of went out to the world once that review had happened. So I'll share a couple of things about the one approach that you might use when you're caring for patients who are detained. So the first thing, like Suzanne mentioned, is context is everything, right? We really need to understand the context. So we need to understand the context of racism, of anti-Black racism, anti-Indigenous racism, of ableism, of how people who are deprived of housing and people who use drugs are discriminated against. Then we need to understand the context of our hospitals. So, I'm sure it won't surprise people on this call to know that there are some really bad hospital policies out there, but you need to know what your policies are, and then you can bring your critical lens to that and advocate for changes to bad hospital policies. But you need to understand sort of what's happening at your institution, what's the expectation. And then also understanding the local context, and perhaps this one rings more true for me because I do locums in different communities. But for example, there are some communities I work in where it's quite standard practice for police to bring somebody who's intoxicated to the emergency department, ask for them to be medically cleared, and then for them to be taken to cells in the local, in this case, OPP detachment to sober up for the night. And so understanding those practice patterns, and then also understanding how you're going to navigate them if you're trying to minimize and reduce reliance on police, reduce interactions with police because of the harms of policing. So that local context is really important. Next thing is your interactions with the patient. So Suzanne talked about that trauma-informed approach. Absolutely. And I think it is incredibly difficult to, well, you really can't implement all facets of a trauma-informed approach when somebody is detained, but there are some things you can do. So the first thing is, I always politely and professionally say to, the police officer, the correctional officer, I need to go see this patient. I'm going to need some privacy to do that. Can you please leave the room? And I don't ask them, I sort of tell them. And if I get any pushback, I say, well, actually, the patient has a right to confidentiality in their medical care, and I need that in order to do a proper assessment. So we're going to need to figure something out. And so sometimes we're able to figure out moving to a different room where the officer can be on the other side of the door. Sometimes it is a matter where, I'm not able to find another room. So I just ask them to stand on as far away as they can while I'm chatting with the patient. I think one area that does come into tension is that the police do not, and correctional officers, they don't have the right to the patient's medical information, but they do have the legal authority to detain a patient and do what they deem necessary to maintain the detention of that patient. And so that means that they may determine that they have to keep eyes on the patient or something like that. And they do have that legal right, although we can certainly critique whether that is ethical or appropriate or just. So I try and negotiate that. Sometimes I'll use written communication with a patient if I'm not able to get enough distance to be out of earshot from whoever's there. But that's really important. Next thing is actually saying to the patient, what you share with me is confidential. And here are the exceptions to that. My records can be subject to a subpoena or a search warrant. I do need to report these mandatory things. However, I'm not going to share your information with the police officer who's there right now. This is a conversation just between you and me for your medical care. There's nothing a sandwich can't fix. I think we all know that. But really, who knows the last time this person has had something to eat, or if they're going to get food, if they're leaving the emergency department to go to a jail or prison or that sort of thing. So making sure somebody has something to eat, something to drink, a warm blanket if they need it, whatever, just making sure that they're as comfortable as they can be. Assessing some of the risks specific to being detained. So it is really shameful the number of times that I've taken care of a pregnant person who's been leg cuffed or handcuffed to a bed. And certainly this immobilization increases their risk of DVT and PE. So there are specific risks of being restrained or detained that I will identify and then either advocate for the medical reason why that needs to change, or at the very least figure out how I'm going to mitigate that risk. And then I think to Suzanne's point about the words, choosing the words we use really carefully in the medical record, it's also really important to document without sort of that negative framing and without editorializing about what we think may or may not have happened. Certainly people get hurt and also killed in police custody. And so, if the patient is reporting that they've been hurt in custody, then making sure that you're documenting any injuries. You can use photos, drawings, whatever. And, of course, we all need to give our medical opinion on what we think happened, but beyond that, not giving our opinion as to the truthfulness of the person sharing or anything like that. And then finally, discharge location. So I think just having some plan for where the person is going to be going, and recognizing that, you know, if someone is going to cell, so for example, like the holding cell at a municipal police department or at an OPP or RCMP detachment or whatever your provincial policing detachment is, there's no medical staff there. They may be able to give some medications. They usually can't give all medications depending on the medication. If someone is going to a provincial or territorial facility, they're, you know, over 2/3 of people who are in a provincial or territorial facility haven't been convicted. They're on what's called remand awaiting trial. And so people can be released at any time, with the healthcare staff at the jail having no idea that they're leaving, or that their charges are being dropped or they're being released. And I don't know if this is true across the country. I would certainly say in Ontario, the healthcare resources in provincial jails are incredibly stretched, and it's very difficult for people to access timely medical care. And then folks who are going to a federal prison are serving sentences of 2 years or longer. And typically there is somewhat better access to healthcare there, more access to consultants, to chronic disease management, to preventative healthcare, those sorts of things. But having an understanding of where your patient is being discharged from the emergency department to may make you reconsider, you know, does this person actually need to be admitted in order to get the care that they need right now? And discussing with the patient if that's something that they would be interested in. And if they would be, then consider whether, you know, even if this patient is someone who you might discharge home, and feel like that was an appropriate plan, discharging them to a detention setting might not actually be a safe and appropriate discharge plan for them. And then finally, of course, like the critical self-reflection piece, when you're working with patients who are detained, what went well, what didn't go well, what do you want to change? What are the points that you need to advocate on at the broader system level? And then teaching learners, you know, when I was a medical student and a resident, I never learned any of this. I came out, the reason that the group of us made the zine together is we were all just sort of floating out in the world trying to navigate these things and had no idea how to do it. So if it's appropriate, you know, giving learners a chance to take care of patients who are detained and talking to them about your approach and asking them, you know, what their approach would be and learning with them. So we've talked about the legal and ethical framework, sort of that floor. We've talked about some of the harm reduction strategies we can use when we're taking care of a patient who is detained. But then finally, I think, you know, to Suzanne's point, this is all about bigger systems. This is all about our work to dismantle racism, to dismantle colonialism, to invest in community care, to defund the police and put those resources towards things that actually, you know, support communities to be healthy on their own terms. And so I think that's the question I would leave us all with, is like, what can we do as people who work as physicians in emergency departments to build life-affirming institutions, to build healthcare systems and emergency health systems that support people and uplift people and support communities to self-determine, and how can we move away from these systems of you know, of punishment and carcerality, but of racism and harm that are currently operating in Canada. So on that note, I'll wrap things up, and I'm really excited to dive into the Q&A with everyone and have some conversations about everything we talked about today.
Fantastic. Thank you so much, Claire. And we will dive right into the Q&A. So reminder for those of you that are watching tonight, please do post your questions in the live stream. We've got some very specific questions around situations we might encounter in the emergency department, and then some broader, more larger questions about our place in the healthcare system and our role in these interactions. So let's start off with one of the more specific questions that we have that's come from the audience. And that's how much investigation is necessary before allowing a patient to leave AMA or discharge them if they're belligerent and you presume or they report having drugs or alcohol. And the person writing the question says, I know it's a judgment call and there's no easy answer, but some guidelines or guidance is always helpful. So any thoughts there? Certainly a common situation in emergency departments. Hey.
I mean, I guess is the question around like having them leave with police or just having them sort of leave on their own?
So my interpretation would be that it's a question of are you, at what point do you say this person is okay to leave and they're upset and we're seeing these behaviors for reasons that are outside of what they need medical care for at the moment. So is this a person who's okay to leave? Or is this a person where you might need to get security, which would potentially lead to restraints and a whole other process? So the challenge of making that decision and being mindful of the person's safety and the risks in both of those decisions. Hey.
Yeah. I can maybe share a few thoughts, and then Suzanne, if you have anything else that you want to add, is that okay? So I mean, I would say that I encounter this. I'm a new to practice physician, but certainly encounter this in rural emergency departments for sure, where I'm working. I mean, I think the first thing is, what are the alternatives? Like, first of all, can we get them into a like quieter, more private space where the lights are dim and it's not this like super busy, stimulating environment? Can we make sure that somebody has food and something to drink and all of these things that, you know, humans need for our bodies and help us to be calm and de-escalate? Can we ask someone like, is there somebody that I can call for you? Is there somebody trusted in your life that could either like come and support you, or that you could leave with, who would be able to support you? I think the question around like, are people okay medically to leave, that really is like your judgment in this situation of whether they can appreciate the risks, you know, like, you know, is it -20 out, and do they understand that they need to like wear a jacket and have a way to get to wherever they're staying that's indoors, or are they like dressed totally inappropriately for the weather and wandering around and that sort of thing? And then like, you know, is calling security your only option? I guess going back to some of those de-escalation things, like, you know, why does the person want to leave? And can we address any of that? And can we make it a more comfortable like space for them to be in, and a place where they can we can bring the intensity down a little bit for them. And then I think the like, what are we getting, you know, let's say that we try all of that and none of that works. I think that's where we need to, as a team, for example, a team of emergency department providers, figure out like, what are our alternatives? What else can we do? Because, you know, the way that we do things now, we just do it this way because we've always done it this way, and this is the only way we've imagined. So it is going to take us coming together and sort of some creativity to figure out other ways of supporting people to be safe besides just calling security. So those would be my thoughts on it.
Thank you.
Suzanne, thank you. First of all, I have to say, Claire, that was an amazing presentation. I love you, the zine. I thought that everything you said was just incredible. I love the idea of life-affirming care through the context of abolition. It was just amazing. So I think it's very interesting because I also worked up north. So I am, although I'm so young looking, I'm not very new to practice. And I worked up north for a long time. And in the communities where I worked, there was no security. There is no OPP. There is no police presence. I did not carry a weapon on me. I was unarmed. Had no taser. I had no gun. You know, I am not a big person. I'm a very small person. And a lot of the time, you really have to think that de-escalation is your only choice. And if you feel that the patient is not safe, you just make it work. And if you feel like, you know, they'll go and come back because of circumstances, you know, then that's something that is such a different world up there. I would say here in the city, we start to have to question our resources at the merge department. If you don't have the right resources to de-escalate someone, then you have the wrong HR policies or the wrong hiring. You know, there should not be the only option is that you can convince them as the emergency doc or the security is going to like pin them to the ground, you know, or tie them to the bed. There should be other options. There should be people on staff that are trained in harm reduction and de-escalation. There could be peer workers. You know, I worked at, for example, a great lesson when I worked for ICHA and I worked at the COVID hotels. A lot of the time that people want to leave AMA might be because they need something that we don't provide in the emerge. It might be that they need a fix. It might be that they need to contact someone. There can be so many reasons that someone leaves. I also think that I have seen some situations in my own clinics here, in my Indigenous clinics, where there's been patients who are just so agitated and scary. You know, like it's actually frightening for me to be interacting with that patient at some point in time, and I feel scared for my safety. And I've watched elders just sweep into the room and calm the person down, offering medicine, offering smudge. There's so many things that people might know, a familiar face. You know, this is why it's really important that we try and say that the only collection of people a patient should see should not just be doctors, security, and police. There has to be more than that. And I think that was really important, you know, when you were saying earlier about the fact that we are seen as part of the same system. And we see that reinforced again and again, where it's like, you know, you call 911 and you don't know if you're going to get police or ambulance. I've called 911 and don't know if I'm getting police or ambulance for my own patients. And sometimes you get the one you don't want. And, you know, you even look at for Indigenous communities in Canada, the profound systemic abuses by police are no joke. And like the community of the Kanjicum, for example, in the middle of a pandemic, you know, allegations that are very serious allegations of misconduct, including sexual violence against people by the OPP were made, and the OPP was expelled from the community. And in response, Health Canada, Indigenous Services Canada pulled the entire healthcare team because it is mandated that police must be in the community to ensure the safety of the medical providers, which is insane, right? So, you know, that is just so crazy to me that these things happen. And I think that the solution is really going to be try and cultivate, notice what you need. You know, if you're running into these situations where you can't calm someone down and they're going to leave AMA and you're worried, just think about it later. Like what resource could have been there? And flip the question. This is the same question that people in the community are thinking, should I call the police? Is this like at this moment, should I call the police to have them taken to hospital? So it's like both ways. It's stressful for us and it's stressful for the community.
Yeah, excellent thoughts. Excellent thoughts. I really, in particular, thinking about the false dichotomy really that we set up, where it's you're leaving AMA or we're calling security, but how there's so much space between those two options that we could explore. And even in retrospect, so Dr. Schuss, that idea of almost having a case review afterwards, the same way when we do with when there are other medical concerns that come up, and about I think that's a fantastic thought that hopefully is prompting some reflection in our audience members as well. We are getting a ton and a half of questions coming in, which is exciting. I am really glad to see everybody engaging with this topic. So Dr. Schuss, Dr. Bodkin, I'm going to give you the very next one up here. One scenario that I find really challenging is trying to minimize minimize police presence in the ED is concerns from other team members. Oftentimes other providers, especially bedside staff, will say they feel more comfortable if the patient is sedated, in restraint, or with police for the duration of their visit, et cetera, citing concerns for their own personal safety. And this certainly goes back to things that you both touched on just in your last response. The person asking the question continues on: as a less experienced team member, I often struggle with what I perceive as someone who I do not have safety concerns about, with the acknowledgement that more experienced team members may have had negative experiences in the past and are also at the bedside more than I am. Do you have any advice for navigating these interactions, so among staff members, in making these kinds of decisions?
I feel like neither of us are going to answer. And we're just like, honestly, I think that it comes down to the fresh eyes. I do think that that's important. There can be huge benefits of someone having, decades of experience. And there can also be disadvantages where you get a little bit baked in to the systems that you might feel jaded by, right? Like you might feel jaded by, you might feel frustrated. You might have seen enough people in the same circumstance. And policing in healthcare is very, very similar in the fact that, you're dealing with very limited time constraints, limited resources, situations of urgency. You need to make decisions. And unfortunately, a lot of us are just making decisions based on implicit bias and baked in racism and prejudices. So I think that using your fresh eyes is important. You should never, I would never sedate someone for my safety. I would sedate them for reasons that are related to their health. I would also relate, and sometimes you think about how agitated is this person? Are they so agitated at this point that that they're suffering and that there is a huge need to step in and medically provide some relief for that patient? I think that this can be seen in so many different circumstances. I think listen to your staff at all times. Your staff, your nurses, your bed, like they do have reasons for wanting things done a certain way. And I think that listening to them is very important and having a conversation. This is not about a hierarchy. I think that we need to really dismantle that hierarchy of physicians, just kind of bulldozing through, because you do need people to feel safe to work with the patient. So listen to them, use your fresh eyes, use your medical judgment, justify what you do or do not do, and justify that. Really, like, even think about if this is gonna, one day your license could depend on the decisions that you made, right? Your license could depend on that one chart in front of you and what happened. And how do you document that? How do you justify that? What is the what is your responsibility? Because even though you are not the king of the castle, you are at the end of the day responsible for the well-being of the patient, and that will be on your shoulders.
I agree with everything Suzanne said, and I will add a couple of things. So as a new staff, and also as somebody who works in communities that aren't my communities, a couple of things. So I have this distinct memory of the first time I was asked to medically clear a patient to send them to the drunk tank. And the nurse asked me to do this. And the thing I said was, oh no, anything but that. Which was not really it was totally a gut response of me just being like, oh no, but that was not helpful. It wasn't, it was not terribly thought out. It was just sort of my immediate reaction. And so a couple of things I think that sort of I learned after that. One was that I debriefed it with a more experienced physician. I said, here's what happened. I wasn't happy with the way that I responded. Can we talk through this? And we actually literally practiced some scripts of me, things that I could say if I was in that situation again. Things like, instead of saying, oh, anything but that, saying oh, what are you concerned about? I'm not comfortable with this because, those sorts of really basic things, but it actually really helped me to do that. And then the other thing I think is, making sure you're providing options. So we may understand that safety is not going to come, and it's certainly not going to come for everyone with security or police around. And like Suzanne said, understanding what are the concerns, what's going on. And then, okay, so could we move this person to a different location and that might be safer? Could we, if the person is medically suffering and in distress, can we make sure that we're treating and alleviating that distress? Maybe they're in pain. Should we be treating the pain? Kind of figuring out all of those sorts of things. And then you know, I think depending on the pressures of flow in your department, this is sometimes easier or harder, but like being present, you know, like frequent reassessments, checking in, how is the nurse or whoever the bedside staff is, how are they doing? Those are all things like no one wants to feel abandoned by somebody who said like, okay, we're not doing this or we have to do that, but then isn't actually there to like work through the sort of ramifications of that. So for me, those have been some of the things that have worked. Yeah.
Excellent. All right. So thank you. Very helpful responses. We have way too many questions to get to tonight, which is a good problem to have. I will ask one last one that is a little different than the other topics we've been talking about. And this is again about patient privacy. So Dr. Botkin, going back a little bit to one of the points you highlighted in your talk, and this is a question about if the police aren't present in the emergency department, but they call to ask if someone is in your department, whether they're there, whether they've been discharged, what's our obligation there?
That's a good question. I mean, my my approach to it is that that's actually still personal health information, like whether or not somebody is admitted. And so I won't personally comment on that, but I think different hospitals have different policies. I'm not sure that that's actually been like tested in the law. I don't know if anybody else has a comment on that.
Suzanne, do you have anything to add?
I would assume the charge nurse would know. I would assume that somebody, you know, you could say, I'm not sure if I can share that with you. I can get back to you, you know, like they could, yeah, I would, if I don't know the answers, I'll just let them know. You don't have to give an answer on the spot. You can let them know you're busy and you'll get back when you can. But I really don't know. I lean towards what Claire said. I wouldn't share that information because also you don't know, is it really the police? Like it could be anyone calling.
And that's another fair point. So I think, yeah, Claire, I think the idea of looking to what your hospital policies are, and so what the guidance your hospital has gotten from your own legal departments and from CMPA would be a great start. And yeah, I think that's an interesting and challenging question for us to end off with. I wonder if we've got 4 minutes left. I wonder if we can squeeze in one last one. This is a question about privacy. And so certainly a concern that many of us have had where we have had police officers who've listened in on conversations, used information that was not meant for their ears. Claire, you mentioned a couple of strategies that you use about asking the police officers to step out of earshot or to be using written materials. Is there anything else that either of you have to suggest in order to maintain patient privacy so that they are able to have a full conversation with you?
Sorry, I don't know if that question was directed to.
That is to both of you. Dive in.
So honestly, the one issue that this might come up frequently is if the patient might be inebriated, intoxicated, or under the influence of anything. At that point, I'll let the police know that when the patient is more sober, they can come and sign a release of information and ask for that. Like I'm not going to ask, I'm not going to try and get consent from someone who's not able to give it. I also think that there is, it often feels very innocent when the police is there to ask questions and you feel like you're on the same team and you're all helping the patient, but you don't know motives. You don't know motives. You don't know histories. You don't know what's going on. This person is essentially a stranger who does have an inordinate and you know, significant amount of power over this person who is your patient who is detained. So I loved all the suggestions that you gave, Claire. I think that that's really important. Asking police to leave even when the patient's like, no problem, they can stay. I don't care. I'm not scared. I'm like, it's not about you being scared. I don't want to. I would rather have a safer conversation without this presence here. But I think that the tips that you gave in your talk were just phenomenal. So thank you.
All right. Thank you, Suzanne. And I think we have 1 minute left. So we'll wrap up there. Thank you to everyone who joined in tonight. Thank you to everyone who posted questions. So excellent interaction. It was great to see. Thank you, of course, to our fantastic speakers this evening. So Dr. Suzanne Schusch and Dr. Claire Bodkin, we're very appreciative of your expertise and your time. Also want to say thank you to Marika Miskalik, a fantastic medical student who's been helping out behind the scenes with the Q&A, to Jeff Allen Productions for the live streaming, to Gail Chapman and Shanna Scarrow and the Canadian Association of Emergency Physicians for the opportunity to hold this session tonight. Thank you as well to the executive of the Anti-Racism and Anti-Colonialism Committee. And I would like to invite anyone who is participating tonight or watching the recording to check out some of the other recordings from Grand Rounds that are particularly relevant to tonight's session. So thinking about this session on trauma-informed care, which was mentioned earlier tonight, as well as the introduction to equity, diversity, and inclusion that was held last year. So a series of excellent sessions worth checking out and relevant to the topic we were discussing. I'd also like to invite you all to check out the social medicine track at CAEP 2022. There was a mention about the peer support programs that have been making a difference in terms of the need for security in the emergency department. And we'll be hearing a presentation about a peer support program established by Dr. Hume and Dr. Heyman here in Toronto. I'd also like to invite anyone interested to attend the large open meeting for the Anti-Racism and Anti-Colonialism Committee on May 31st, also as part of CAEP 22. Okay. Thank you all again for joining in this evening, and please take care and stay safe.